Okay. I'm done. Ready. I hope the slides are visible.
Yes.
Yes. Thank you.
Good evening, everyone. We welcome you all to OrthoTV. This webinar is brought to you in association with an educational support from Intas, Inara, the makers of Terifrac and Olimab. And to introduce today's topic and speakers, I hand over to Dr. Amit Jain. Over to you, sir.
Okay. Thank you so much, Dr. Neeraj. Very good evening, esteemed delegates. I know that all of us are day in and day out engaged in management of patients. But while we are so busy in doing our clinical practice, there are a lot many questions which always remain unanswered. We always try to find the answers to a lot many questions when it comes to diagnosis, management, or all, and we are always confused whether answer is yes, no, maybe, don't know. And it most of the times it seems that yes, we need a perspective to understand that particular question as well as to find answer to it. Like many times, if we just have a single-sided perspective, the answer what we perceive might be absolutely different. While if we have a perspective of from the 360-degree view of whatever thing we are actually talking about, in that case, yes, it becomes quite clear and we can really manage the cases absolutely in a different way. Like in medical, a two-dimensional X-ray which just give a one-sided view is always inferior to a three-dimensional view in the form of CT scan, which helps us to really understand that what is the basic pathology. Especially when it comes to the management of geriatric patients, it is more important. Why? Because we know that geriatric patients, they are always suffering from a lot many disorders, a lot many comorbidities are there. So just managing a single side might not be enough. In that case, while we manage this, it would be almost humanly impossible for a single person or a single specialty to treat all the morbidities which a geriatric patient really suffers with. So in that case, yes, what is required is a multi-specialty, multi-pronged approach to manage those conditions, and various specialties are required. So here to have a 360-degree and holistic view of the geriatric care, I, Dr. Amit Jain from Medical Affairs Department, Intas, on behalf of Division Inara, which is specifically dedicated to the management of osteoporosis with the products like Terifrac as well as Olimab. And invite all of you in this today's, I would say, webinar, which is Advances in Orthoneurogeriatrics under the aegis of Kaveri Hospital. So let me take the opportunity to introduce our today's moderator. Our moderator today is Dr. Kirti Vasan. He is orthopedic spine surgeon and currently associated with Kaveri Hospital. So without taking much of your time, let me hand over the session to our moderator. Over to you, sir.
Thank you, Dr. Amit. Good evening to all. So today, most of our discussion will be in the advances as well as the essential care in orthoneurogeriatrics. So the challenges in elderly patients are a lot, and there is many things. And one of the main things is lack of awareness among the patient as well as the caregiver about the treatment options available, as well as they are more afraid about the senility and avoid proper treatments. The comorbidities are also prevalent among this population, and they need specialized infrastructure as well as dedicated manpower. The economic factor is a major concern among the elderly patients because they are mostly dependent among their offspring, and their economic concern is a major issue. So ours is a center of excellence in orthoneurogeriatrics because we cater to a specific population who are mostly educated. And ours is a dedicated center with a specialist and infrastructure to deal with elderly population especially. And the role of insurance also plays a major role in the treatment in our patients, because most of our patients are covered by the self-insurance, or they are dependent on the insurance of their offspring. So to introduce our speakers, we have first Dr. Aravindan who is a co-founder and executive director of a Kaveri Hospital. He has a master's from Gujarat University with a gold medal. He spent 15 years in Ireland and UK in most esteemed institutes like King's, Guy's and St. Thomas Hospital. He has many awards, and some to mention a few: the Best Doctor Award by Tamil Nadu Government and the Pride of Tamil Nadu Award in 2018. Next, we have Dr. G. Balamurali, Head of Spine and Neurosurgery, Kaveri Hospital, Managing Director of Kamsa Rehabilitation Center. He has more than 15 years of surgical training and work experience in UK, USA, and Switzerland. He has many awards to his credit. To mention a few: Best Contribution to Society Award from Dr. APJ Abdul Kalam, and he was mentioned as one of the most influential person of Chennai in 2020. He has many publications and book chapters. Next, we have Dr. Bhavaneshvari Rajendran, who is a head of clinical neurophysiology services in Kaveri Hospital. She had a postgraduate degree from UK, and she has worked more than 12 years in most prestigious institutions in London. A special interest in neuromuscular disorders, stroke, and neuroinflammations. So, she has an Innovative Healthcare Leadership Award in the Department of Neurology. Then we have our consultant head anesthesiologist, Dr. Velmuragan, who is an area of expertise in pediatric anesthesia and regional burns. And now I invite Dr. Aravindan Selvaraj for his talk about orthogeriatric surgery, care beyond surgery.
Hi, good evening, everyone. Thanks to my colleagues, Dr. Kirthivasan and Intas for this opportunity. Orthogeriatrics is not a new term. It has been in work for the past 25 years or so, but fairly new in recent in India. Why it is very relevant at this point of time is we are seeing a significantly increase in the number of elderly patients with the fragility fractures and the complications associated with this fracture in our orthopedic practice. So we started this department of orthogeriatrics, first of its kind in India in Kaveri Hospital, Chennai, in June 2015. It combines the medical specialties of orthopedic as well as the geriatric medicine to provide a holistic care with the infrastructure, the medical management, combined with the post-discharge, the care for the patients. So the orthogeriatric team comprises of orthopedic surgeons, the geriatric physicians who are specialists in the elderly geriatric care, the anesthetist, critical care physician, the nurses who are specialists in the geriatric care, the geriatric physiotherapist, and geriatric occupational therapist. What made us to start this department? I practiced for 15 years in UK and Ireland, where I started my practice in Ireland in 1995, and the population demography was already skewed more towards the geriatric population at that point of time. So we in a trauma department where I worked in Belfast, in a single day I used to see 20 to 25 patients with the hip fractures in elderly, the fragility fractures. So the orthogeriatric department was well developed even at that point of time. And we are seeing in India as well, as the population ages, we are seeing a number of patients who live beyond 80, 90 years coming with the hip fractures and with this attendant risk and the complications. So when I returned back and started this Kaveri Hospital in Chennai in 2010, we conceptualized this orthogeriatric department, and we started this department in 2015 in Chennai Kaveri Hospital. Increasing geriatric population. The geriatric problem is not going to be exclusive to the Western and only the developed countries, but as the projection says, by the year 2050, more than 50% of the senior citizens or more than 50% of the geriatric population will live in developing countries like India and China alone. So we are going to see a significant increase in the people in the senior citizens age group and with the resultant problems as well. There's no doubt there's a higher morbidity and mortality after fragility fractures or other porotic fractures in this population. And also, once somebody has a fragility fracture, there is a higher chance that they will have another fragility fracture, if not in immediate future or in later times. So the fragility fractures management is, though the basic principles remain the same, this poses a different kind of challenge in terms of quality of the bone and its the ability of the fracture to heal, and also the implant considerations. That's why the orthogeriatric department has got a special relevance in this current day and age. So morbidity and mortality after fragility fracture. If you see this slide, after an elderly patient with an osteoporotic fracture, if you take from the right hand corner the death, irrespective of the best of the treatment you offer, the early fixation, the early mobilization, within 3 months, nearly 12% of the people will die, and it goes up to 21% within the first year. This is irrespective of the best management. Then, if you say that how much percentage of the people will be able to walk without support and going back to the active lifestyle, it's less than 3% only after 12 months. So it produces a significant burden on the hospitals, the caregivers, and the society in general. So the morbidity and mortality after fragility fracture continues to remain high. This is a very important one because how much percentage of the people return back to their independence and autonomy in their activities of the daily living. If you look at that bar on the black is post the fracture stabilization, and the gray one is the pre-fracture. So the very few people return back to this autonomy and independence after this fragility fractures. This is irrespective of the best treatment being offered. So the special considerations in this geriatric population, most of them will have comorbidities with the hypertension being the highest one, and the osteoporotic bone, particularly more so in women, the postmenopausal age group, and their immunity will be compromised because of the various comorbidities like diabetes, and also because of the poor muscle strength, they recover very slow after hip fracture fixation. The prevalence of comorbidities in the hip fracture. You see this hypertension is one of the commonest comorbidity, followed by anemias, fluid and electrolyte disorders, pulmonary disease, and diabetes, and so on. So when we set up the department, to set up the guidelines for our department, we adapted the blue book, which was brought out by the British Orthopaedic Association, which defined the standards for this orthogeriatric department. So all patients with a hip fracture will be admitted to the orthopedic ward within 4 hours of presentation. All patients with hip fracture who are medically fit should have surgery within 48 hours during the normal working hours. Why this 48 hours? I remember when I was working in the UK, if we don't operate on a patient with a hip fracture, fragility fracture within 48 hours, we need to fill out a form which was directly linked to the Department of Health website, justifying the reasons why we have not done the surgery within 48 hours of admission. All the hip fractures patients will be capped so that they minimizing the risk of the pressure ulcer, and all the patients presenting with the fragility fracture should have an access to the orthogeriatric physician and medical management, and all the patients with the fragility fractures should be started on osteoporosis medication management, and all these patients will undergo multidisciplinary approach to prevent the further risk of falls. These are the 6 parameters we adapted from the Blue Book by the British Orthopaedic Association to set a benchmark of our clinical care. So the essential steps in the emergency management: as soon as the patient, elderly patient with a hip fracture presents to the ER department, we should not delay in any admission process. Many times they get stuck in the emergency department with irrelevant and unnecessary investigations, sometimes even MRI scan and all. No, they should be undergo a quick evaluation, and they should be admitted in the orthogeriatric department at the shortest possible time. And adequate pain control is the key, because these elderly patients with a lot of pain, it will lead to mental confusion. And the bladder catheterization should be done in all female patients, and also the male patients with incontinent bladder and altered consciousness. They should be screened for urinary tract infection, because that can further lead to mental confusion. They all should be well hydrated. And the preoperative optimization, and most of the time if you see this, the patient is at his best at the time of injury. Whatever you do after that is unlikely to improve his medical condition significantly. That's why we say that try to surgically stabilize them within 48 hours. Anyway, with the preoperative optimization, we have to assess the cognitive dysfunction, if there are electrolyte imbalances which needs to be corrected, if there's a coagulopathy disorders, this needs to be addressed. Also, we should get a cardiologist review to optimize the cardiac function, and also the medications. And many times these elderly people are on multiple medications, so the polypharmacy. So we should optimize the medications and giving them the only minimum which is needed. So the non-operative versus operative management. In India, particularly, if we see a problem many times, even if the patient is willing for surgery, the patient's sons and daughters, they will say that no, my mom or dad won't cope up with surgery, so we will manage without the surgery. So it become our duty to explain to them why the surgery is very important. At this day and age, I don't think we should be talking about the non-operative management at all, because there's a significant mortality associated with the non-operative management within the first 1 month after this fracture. So we do spend some time in explaining to the patient's relatives that even if the surgical risk is very high, the surgical management is the gold standard treatment in this elderly patients with the fragility fractures. The timing of the surgery, time and again the evidence is keeps coming back saying that we should operate on them less than 48 hours unless otherwise there's a medical condition which can be reversed with a prolonged medical management. And there is 48 hours, but preferably even within less than 24 hours is even better. We always have problems with anesthetists saying that patient is on aspirin and clopidogrel, so we should postpone the surgery for 4 to 5 days. That battle keeps continuing, but I keep insisting on to my anesthetists that however there is a limited evidence, there isn't a good evidence to support that even patients with aspirin and clopidogrel can be operated early. But this will go on for some more time until the anesthetists get convinced that by operating early, we are helping the patients to recover faster. How to avoid delay? Within 1 hour of the admission, our patients are seen by the geriatric physician as well as by the anesthetist, and we agree on a treatment optimization plan and schedule the patient for surgery. The next available list, the first patient in the morning list. Please don't leave these surgeries for out of hours trauma list. These patients need extra care. They should be first on the list on the next day preferably. The surgical considerations, the operative technique, it is definitely far more challenging than operating on a young 30 or 35-year-old patients with a similar kind of fractures. If it is a intracapsular fractures, we go for normally a hemiarthroplasty or a total hip replacement, and if it is an extracapsular intertrochanter fracture, we go ahead with a fixation, preferably with the proximal femoral nail or the dynamic hip screw. So total hip replacement versus a hemiarthroplasty in a fractured hip in elderly people. Previously, there was a concern about doing a total hip replacement in these patients because of the higher incidence of complication like a dislocation. But our technique and implants have far significantly improved, and total hip replacement provides superior outcome when compared with hemiarthroplasty, particularly in people who are less than 80 years of age and who has got more than 4 years of life expectancy. Whereas people more than 80 years and then less than 4 years of life expectancy, a hemiarthroplasty gives good results as well. Cemented versus uncemented. For a quicker surgery, many surgeons used to prefer uncemented hemi or total hip replacement, but the uncemented the hip replacement has got its own challenges with the patients presenting back with the thigh pain and the intraoperative and postoperative periprosthetic fracture. So our preference and the evidence is also more in favor of cemented hip replacement or hemiarthroplasty in these patients with intracapsular fracture neck of femur. Many times these people the patients have got illnesses like Parkinsonism and the stroke, neuromuscular disorders. To prevent the risk of dislocation, we use a dual mobility, the hip replacement with the cup, which reduces the chances of dislocation. And if it is extracapsular trochanteric fractures, we fix it with dynamic hip screw or proximal femoral nailing. Because of the poor quality of the bone, sometimes the implant can fail before the fracture heals. And one thing we have to understand is all these people have got only one chance with for surgery. You do a good surgery, they recover very well. For some reasons, if the surgery leads to complications, they don't do that well after their second fracture surgery. So we try to get the best of the implants possible. Now we get this augmented, cement augmented fracture fixation devices or the special interlocking screw fixation in the proximal femoral nail. With this, we minimize the complications like the screw cutout or the implant failure. Sometimes even in extracapsular fractures, we do hemiarthroplasty if the fracture is severely communicated or if the patient has got already an evidence of degenerative arthritis and if the bone is severely osteoporotic, which will compromise on the internal fixation, or a failed internal fixation also can be considered for hemiarthroplasty or total hip replacement. The postoperative care is the fundamental in restoring the pre-injury level of mobility in these patients. Early mobilizations. Many times I see orthopods saying to the patients or the therapists, because of not so good fixation or various reasons, they say non-weight bearing mobilization. A 80-year-old is not going to mobilize if you say that you should not put weight on the affected hip. They all should be aggressively mobilized very early, preferably the same day or the next day after the surgery. This minimizes the hospital complications like the DVT and the pulmonary atelectasis and all. So our dietitian is very actively involved in the management of them, as well as the urologist and the continence care. But one of the things which has improved outcome in our patient is we have got an extensive rehabilitation program which is planned at the time of surgery itself about how they are going to manage at home. This post-op rehab program is well established in the Western world. In our hospital, we have got a rehab center, which is a 30-bedded rehab center for this elderly patients. If they can go to the rehab, or if the patients want to go home with the adequate support, we have got an extended home care. Nowadays, these patients don't come back to us for the stitch removal or catheter removal or dressing change. All this thing is provided by our extended home care delivery team, which does regular periodic monitoring. Our physiotherapists visit them every day at home, and our nurses go ahead with the dressing and removal of stitches. They come back with a video call so that we monitor them mobilizing at home. And the next visit to the hospital may be only after 3 to 6 months time when they are up and mobilizing fully well with for a check X-ray. So most of these patients get discharged on the 4th or 5th day after surgery, but our care doesn't stop at the hospital. It extends to home. That has significantly improved the outcome of these patients. But one important thing is many times as orthopedic surgeons, we don't focus on the osteoporosis management. Because we work very closely with the geriatric physicians, we evaluate them for osteoporosis, and all these patients get this vitamin D 6 lakh units during the in-hospital admission itself, followed by the management with the biphosphonates or teriparatide, vitamin D and calcium. And falls prevention, as I said earlier, these patients are prone to develop another fragility fractures because of the fall, and these patients attend the falls prevention clinic by education, exercises, and the modification, eye care, as well as addressing of the foot problems, and also the walking aid modification. Important thing is home modifications. Our occupational therapy team visits them and ensure that they have got a non-slippery floor, and as well as the railings on the staircases with enough lighting. So all these things are come under the falls prevention clinic with the help of the geriatric physician as well as the neurologist. We run this clinic very effectively. Thank you. Thanks again for everyone for giving this opportunity and listening to me. Thank you.
Thank you, sir. That was a very nice explanation about advances as well as recent care in the Department of Orthoneurogeriatrics. Now I request Dr. Bhavaneshvari to give her presentation about falls prevention in elderly patients. Welcome, ma'am.
Good evening, everybody. I'm Dr. Bhavaneshvari. At the outset, I would like to thank Dr. Kirthivasan, the spine team, and Intas for this opportunity. We've just heard Dr. Aravindan talk to us extensively about the patients who come in with falls and fracture and how important it is to do a prompt evaluation and surgery to give them the quality of life that they deserve. So I'm going to talk to you today about a very common and a very difficult to treat issue, which is falls in the elderly. We come across this in our clinical practice every day. We see so many patients with background medical problems, with instability and so on. So what do we do for these patients? How do you prevent them from having a fall? So this must be part of our examination and management of patient. I'm just going to start sharing my screen right now. So the presentation. I hope you're able to see my PPT.
Yes, ma'am.
Okay. So as I told you earlier, it's a very important issue. It's a very common problem. And the fall may look innocuous, but the injuries sustained by these elderly patients are so profound and it can be life-changing. It causes lifelong disability, huge compromise on quality of life for the patient. And in most cases, patients are living with their families, with their children. And it's a huge burden on the family, physically, mentally, and financially. So how do we prevent these patients from falling? And what is the problem in large as the magnitude of the problem when you look at it around the world? Now, we all know falls causes major morbidity and disability in the elderly. When we talk about elderly, we are talking about anyone over 60 or 65 years of age. And you must understand, if they have background medical problems, cognitive impairment, or history of falls, their risk of falls is definitely going to go up more and more. And if you look at statistics, WHO actually says about 80% of falls occur in the low and middle income countries, especially Southeast Asia, which accounts for almost 60% of fall related mortality. That's alarming. That's extremely alarming, because in a country like India, as I mentioned earlier, most elderly patients are either living alone or living with families. So falls leads to a major setback in their lives. So it's important that we prevent falls in these patients. Now, when we look at the risk factors for falls, we broadly categorize it into three major headings. Intrinsic factor. So as the patient ages, there are a few things that is getting lowered. For example, the gait is affected. You may not be walking straight. There might be a little bit of shakiness. The balance is disturbed. His vision may not be 100%. His or her hearing is not great. Their depth perception, dark and light adaptation, all this gets affected. Muscle power is a bit lower. So these factors affect their stability and balance in general. When you look at the eccentric factor, what is happening at their houses, the clutter in their house, the things around them, is there a risk of tripping and falling? These factors need to be looked at as well. Situation. So many times when they are doing a particular job, there is a phone ringing, they have to go pick up the phone. In the nights, when they're trying to go to the loo, they don't switch on the lights, they rush to the toilet, they may trip and fall there. So all these factors have to be taken into consideration when somebody comes in with a history of fall, however innocuous it is. Now, one of the commonest causes for falls in the elderly is orthostatic hypotension. Now, in all of us, what happens is when we change posture, say from a lying to sitting or sitting to standing, there's a minimal fall in the blood pressure. However, in certain elderly patients, especially if they have background medical problems such as neuropathy with autonomic neuropathies or Parkinson's disease with autonomic involvement, their risk goes up. So what happens is there is a higher fall in the blood pressure. So there's more than 20 millimeter Hg fall of the systolic blood pressure, which makes these patients feel a little bit dizzy. Sometimes they can even have a syncopal episode. They may faint and fall, and it is quite scary to look at. And in those patients, we have to immediately identify this problem. So if someone comes with fall, checking the blood pressure, lying, standing, or sitting, standing is very, very important. And if it is established that they have orthostatic hypotension, we need to immediately review the medication, look at the antihypertensives that the patient is having, look at other medical problems, whether it causes autonomic neuropathy, give them interventions such as giving them compression stockings to reduce the fall, or reducing medication or adding medication in some instances like midodrine or fludrocortisone to minimize this fall in the blood pressure becomes very, very important. Now, patients with neurological problems. There are multiple neurological problems where your muscle power, your balance, your gait is compromised, such as dementia, Parkinson's disease, stroke, multiple sclerosis, patient with severe epilepsy, neuropathies. All these problems causes issues with gait and balance. Stroke patients, See, we doctors, we talk so much about acute stroke management, treatment. What do you do in the golden hour? How can you reduce the impact of stroke on the brain? We must also understand patients after a stroke may have disability ranging from minimal to severe, causing problems with gait, with mobility. So what happens is they are at a higher risk of falls post-stroke. So very important to have this rehabilitation program start early in stroke management so that the gait is improved, the mobility is improved using assisted devices, a walking stick or a walker to improve their mobility, minimize falls. So this is very, very important. Occupational therapy involvement, physiotherapy, speech therapy, looking at factors like depression post-stroke, all these factors come into not just post-stroke management, but it's also about how to ensure that the patient has got a good quality of life post-stroke. Parkinson's disease. Now, Parkinson's disease per se gives you slowing of movement, rigidity of the patient's muscles, and also a postural instability. See, when they are walking, when they're changing directions, there may be a slight sway to the right or left. And as a result, there is a very high risk of fall, especially if there is compromise of lighting or if there is things around, they can trip and fall. So patients with Parkinson's disease, when we look at the treatment of Parkinson's disease, it's not just about treatment. I insist on regular physiotherapy because correction of gait and balance makes a huge difference to the quality of life of these patients. So we have to address this problem right at the beginning. You do not wait for Parkinson's disease to advance and then talk about physiotherapy. We need to talk about physiotherapy. We need to talk about occupational therapy, intervention to prevent falls right at the beginning of diagnosis. Because if you look at what causes falls in Parkinson's, as I said earlier, the disease itself, the drugs, because some of the drugs that we use, like dopamine, agonist or syndopa, or they also can cause orthostatic hypotension and hallucinations in these patients. So it's important that we look at all these factors when we are trying to ensure that these patients not only have a good life, but we also prevent falls in these patients. Dementia. It is extremely sad because these patients don't even have the insight. They don't even know what they're doing. Sometimes advanced dementia, it is a huge burden on the caretakers. So education of the caretakers about the risk of falls, how to minimize falls in patients with dementia should start right at the beginning. It is important to educate the family, to educate the caregivers about the risk of falls. What can we do to minimize the fall? So when we are seeing these patients in our clinics on a regular basis, every time they come in, there should be a quick assessment of falls, the risk of falls, so that we make sure that these patients don't end up with major fractures. Neuromuscular disorders, especially neuropathy, which is a very, very common problem. Many diabetics in our country end up with neuropathy as a complication of diabetes. Now, when we talk about neuropathy, yes, there are medications for symptomatic control of neuropathic symptoms, but it is also important that we ensure that these patients get regular physiotherapy to improve their balance so that their risk of falls are minimized. Now, foot care is something that I always talk to my patients about. I always say foot care and foot care wear are two important things that is going to ensure that patient is walking well, the risk of falls is reduced. Many a times you will see that patients are walking with slippers where the toes are holding on to the slippers. Half the time they don't even know because of the numbness whether the slipper is there in the foot or not. And it's actually a tripping risk. So I tell them, please wear sandals. Please wear good walking shoes, insoles, socks. All these little interventions makes a huge impact on their quality of life. So as I said earlier, as doctors, we should not just look at the medical management of these conditions. We should have a holistic approach. We should make sure that we assess risk of falls every time they come in and do interventions that is going to help patients. So elderly patients on the whole, when we are looking at them, we want to know what is the risk assessment for falls, risk assessment of falls. Now, we start with looking at their background medical problems. What do they have? Hypertension, diabetes, neuropathy. Do they have dementia? Do they have Parkinson's disease? Do they have any autonomic involvement? What is their blood pressure lying and standing? Blood test. Is there any metabolic problems? This is very important when a patient comes to you with a history of falls. You have to immediately make sure there's no metabolic dysfunction, there is no infection. How is his gait? How is he maintaining balance? Vitamin D levels, risk of osteoporosis. And of course, there is another very, very major problem, which is called syncope. So it is loss of consciousness, small, brief episode where the patient just has a brief loss of consciousness. It could be because of a cardiac cause, underlying arrhythmias, or heart blocks, which is causing the syncope, or a late onset seizure or a TIA, which is causing the syncope. So these questions have to be asked. The vision needs to be checked, hearing needs to be checked and corrected. What is their footwear like? Are they wearing the right footwear? Podiatrists, are they visiting podiatrists? Make sure you send a team to their houses. Make sure their houses are uncluttered, their rooms are well lit. And how do we do that? So it is very, very important. As I told earlier, syncope is something that we commonly see in elderly patients. These are brief episodes of loss of consciousness. These patients have to be evaluated extensively. Even if it is one syncope, we have to make sure it is not orthostatic hypotension causing syncope. There is no cardiac cause, neurological cause, and cardiac evaluation should not be just one ECG, because many a times we miss arrhythmias, we miss heart blocks by just doing a 12-lead ECG. So we have to do prolonged cardiac monitoring, like 24 hours to 48 hours, even 3 days. Sometimes if there are too many falls and you're strongly suspecting heart blocks, even a week-long recording is important. So what do we do at home? Now, most falls happen in the toilet, in the bathroom. So having a bathroom or a toilet with handrails, and our toilets, especially in India, many of them are not dry toilets. It's very wet. The floors are very slippery. So if a patient is having history of falls or it's got balance issues, it's important that we do inspect the toilet at their houses and talk to the patient about improving the circumstances at home. They make sure that the toilets have anti-skid flooring, at least a mat where they are having their shower, handrails near the WC, and handrails where they are having their shower. If possible, if they are very much compromised in terms of their balance, then even a seat in the area of shower is important to prevent falls. When you have a staircase, yes, we have a railing by the side, but if there is a handrail on the wall on the other side, holding on to both will also reduce risk of falls. So simple measures, simple things will make a huge impact on the quality of life of these patients. Many of our patients have hesitations about using assisted devices or aids for mobility. Talk to the patient, talk to the families. When we age, sometimes we wear glasses. We have to wear hearing aids. Similarly, when we have problems with balance, it is important to use a walking stick, even sometimes a walking stick with 3-prong at the end, so that the stability is better. And patients with advanced neurological condition where the risk of falls is higher, even a walker makes a huge difference to these patients' life. Very, very important, last but not the least, balance exercises. Whatever your condition is, even if you do not have major medical problems, as we get older, teach patients to do regular exercises to improve their balance. This should become part of our treatment for any older patient. So we tell them how to do these exercises. In fact, in Kaveri, we've actually got a great rehabilitation unit attached to the hospital. We have physiotherapists who are looking at improving balance in patients, and we are actually going to be releasing a video, simple video, to teach patients how to do simple exercises at home to improve balance and reduce risk of falls. So, holistic approach. How do we go about? Medically, you look at their background medical problems, you review all their medications, you make sure they do not have simple things like orthostatic hypotension, which is going to increase their falls. You make sure that their vision is improved, their hearing is better, they are treated with vitamin D, they are treated for osteoporosis. Look at their homes, make sure that their homes are safe, there is no risk of falls at home, their lighting is good, their bathrooms are not very slippery. Teach them how to keep it clean and dry. Improve their use handrails. Use handrails near the staircase. All these little things are going to make a huge difference to this quality of life of this patient. And that way, we minimize falls, we minimize mortality in these patients, and make their lives better. Thank you.
Thank you, ma'am. Thank you for the detailed insight into the techniques to prevent fall in the elderly patients. Next, I invite Dr. Velmuragan, or a consultant anesthesiologist, about the advances in geriatric anesthesia.
Thanks, Kirti. Thank you very much. Thank you, everyone. Good evening, everyone. Today, I'm going to talk about the recent advances in geriatric anesthesia. So, the geriatric age group starts with age 65 years. In a classification, it's been given that age between 60 to 69 years are called young old, age between 70 to 79 years are old, and age above 80 years are older old. Why these classifications are important? Because as the age progresses, their physiological reserve comes down. That's a key. Why the geriatric discussion is so crucial at this point of time? There is a rise in geriatric population in India from 18 million during independence to 75 million in 2001. It is expected to rise about 300 million by 2050. That is, by this time, it should be around 100 million. That means 10 crore geriatric population are in the country, out of which 50% will require 1 or 2 surgeries. That means we are somewhere around 10 crores to 20 crores surgeries are going to happen in the next few years. That's a huge number. That's why this topic is very, very important. What are the challenges ahead of us? Like pediatric age group, the geriatric age group are special because they have a decreased physiological reserve and functional capacity. They have a poor nutritional status. Especially the problem comes when we have a major or emergency surgery because of their poor reserves, comorbid illness, and their ASA physical status. Usually they'll come with a physical status of 2 or 3. So lesser disturbances in the already compromised physiology is the key. We have to disturb it as less as possible. Pre-op optimization, adequate pre-op optimization, yearly mobilization and feeding, good hydration and pain control, reducing the incidence of delirium and things that worsens dementia. This is very, very, very important because this is going to reduce the morbidity and mortality. Most importantly, reduce the drugs and the interventions as much as possible. The American Society of Geriatric Surgeons, along with the geriatricians and the Anesthesia Society, has set clear-cut guidelines. They are mostly of what we do basically for all these patients in a most comprehensive manner. They call it as a NSQIP, that is National Surgical Quality Improvement Program. They have set some guidelines. They have 2 parts. The part 1 is assessment. This is very, very important. They have comprehensive geriatric assessment package that consists contains 9 assessment categories. Number 1 is cognitive and behavioral disorder, and that should be documented. The second and third thing are cardiac and pulmonary evaluation, which we normally do for all geriatric patients. Functional status, how to assess a functional status of a patient. Frailty is nothing but syndrome of decreased physiological reserve. As I said earlier, as the age progresses, the physiological reserve comes down, and hence their fight against a stress like an anesthesia and a surgery is going to be a challenge. Assessment of nutritional status, medical management, what we are going to do. Patient counseling, pre-op testing, all these things are important. In patient counseling, 2 things are important. One thing is what exactly the patient wants, how much aggressive intervention they are ready to accept. The second thing is we should, the decision maker, either the patient or the surrogate decision maker, that should be documented. That is very, very important in patient counseling. Regarding this assessment package, I'm going to talk only about cognition and the functional status. All other things which we normally do, how to do. In cognition and dementia assessment, we have lot of scales are available. The easiest and simplest way they recommended is mini-cog assessment. This is the chart. This is, give them 3 words, any 3 words like Shivaji Ganesan, Sachin Tendulkar, Joe Biden, or something like that, or Mumbai, something like that. Give them 3 words. Ask them to do a recall. They're able to do 3 words recall, they don't have any dementia. They're not able to do a single word recall, they have dementia. In between 1 or 2 words they are able to recall, can do what we call it as a clock drawing test, CDT. Ask them to draw a clock with a time like 10:10 a.m. They're able to draw a round clock with a thorn small and bigger one. They are able to do a normal CDT. If it's a normal CDT, then they don't have a dementia. If they have an abnormal CDT, they have a suspected dementia. This has to be documented for references. Functional status assessments. There are a lot of ways to assess a functional statement. 2 ways which is simplest and easiest is activities of daily living. That is, ask them whether they can do daily routine activities like going to the restroom, walk for a short distance, or if they're able to climb 1 or 2 flights of staircases, their functional status is really good. The second thing is time up and go test. That is tuck test, what we call it as. Task is to raise them from a standard armchair, walk to a 3-meter mark away, turn, walk back and sit down again. If they're able to do this test, that's really good because that can assess the joints, muscle strength, their mentation, their vestibular apparatus. All these things are assessed in this tuck test. Those who are dependent on someone in their day-to-day activities and they have an unfavorable tuck test had a significant 1-year mortality. This has to be documented, the functional status. The other one is frailty scale. As I said earlier, frailty is nothing but as the age progresses, their organ reserves comes down. So the simple picture, you can imagine the picture. This man is running, is very fit. These 2 people, bedridden or terminally ill, or they have a very poor outcome. So the morbidity and mortality goes up. The NSQAP guidelines, as I said earlier, the second part is about 3 domains. Domain 1 is immediate pre-op, intra-op, and immediate post-op. A comprehensive, coherent, multidisciplinary approach, as earlier said, is very, very important. Immediate pre-op, confirm patient goals and advanced directives. We know what are the patient goals. They want to walk earlier and eat earlier, go home earlier. That are usually the patient goals. Advanced directives are nothing but, suppose, usually these patients will come with a lot of comorbids, with a lot of medical illness. So how far they wanted to go. Suppose some patient would like to give us a DNR, DL research if something happens. Those kind of things has to be documented. And the most important thing is a surrogate decision maker who is going to take decisions if they are not able to take decisions during or after the surgery. If pre-existing advanced directives are there, then discuss and plan new risk and its plans. The more important thing is regarding the NPO status. 6 hours for solid food, but clear liquids you can give till 2 hours before the surgery. Please give them clear liquids till 2 hours before the surgery. Add to the best practicing guidelines regarding the prophylactic and the antibiotic and the thromboembolism. So in our institution, we do have what antibiotic to be given, when to be given, and thromboembolism prophylaxis, what to be given and when to be started. We have clear-cut guidelines. Stop unnecessary medication. This is very, very, very important because already the polypharmacy is the most important problem currently in our era. Preemptive analgesia. This is one of the wonderful concept developed. How the preemptive analgesia works is the analgesic should be given and must be given before the skin incision, because that will reduce the central nociception stimulus, which will reduce the post-operative pain, analgesic requirements, and opioid requirements. So preemptive analgesia is very, very important. Consider regional techniques to avoid post-op complication and good pain control. Always go for a multimodal pain control and avoid opioids as much as possible in a geriatric population or a milder opioids. Strategies and avoid pressure ulcer and nerve damage before, during, and after the surgery positions, as well as during shifting. Prevention of post-op pulmonary complication and hypothermia. They're very, very, very prone to hypothermia. Fluid management, very, very crucial. Fluid management is not a one-stop sign. Give 75 ml per hour. That's not going to work. Every couple of or once in 3 hours, you have to review the fluid status, or at least 2 to 3 times a day. Now coming to the anesthesia modalities. There are no proven studies that single anesthetic mode is better than the other. That is regional versus anesthesia. So plan in a customized manner for each and every patient according to their physiology, as well as the drugs they are taken, their comorbid illness. But in certain scenarios, like hip fracture surgeries and elective hip and knee surgeries, a lot of studies has been done, and regionally is proven to be better than general anesthesia in 30-day mortality, in reducing the vascular complication, reducing the thromboembolic complication. So in these surgeries, definitely neuroaxial anesthesia is better than the general anesthesia. But ultrasound guided nerve blocks has revolutionized the way we practice by increasing the success of adequate surgical anesthesia with lesser sedation and hence yearly mobilization and feeding. It gives good post-op pain control. It gives good supplementation if associated with general anesthesia or a neuroaxial blockade. For an example, in our institution for all hip fractures, we give spinal anesthesia with fascia iliaca compartment block. That gives very good post-op analgesia, earlier mobilization with lesser post-operative opioid requirements. So earlier discharge. So options of anesthesia are general anesthesia using an endotracheal tube or a laryngeal mask airway, which can be supplemented with a nerve block. Spinal anesthesia, epidural anesthesia. Nerve block, it can be given alone or as a supplementation. For an example, a patient coming with a forearm fracture, this 80-year-old man coming with a forearm fracture with an ejection fraction of 25%. If we give general anesthesia, we have to start them on inotropes, noradrenaline, we have to place an intra-arterial line. A lot of things are there. But if we can do this surgery with an infraclavicular or a costaclavicular nerve block or an axillary nerve block with the help of an ultrasound, this block can be done as a sole anesthetic agent with a nerve block without any inotropic support. That will reduce the morbidity and mortality. So these are few upper limb blocks, brachial plexus blocks, interscalene, supraclavicular, infraclavicular. Out of this, a costaclavicular block is a wonderful block. We used to practice a lot in our institution. This is called spinal anesthesia of the upper limb because it's a single point injection. Gives very good block for surgeries at and below the elbow. For lower limb blocks, femoral block, fascia iliaca block, sciatic adductor canal block, popliteal block. For an example, giving a popliteal block and a femoral block, all the surgeries below the knee can be done without any, not even a sedation also. Immediate post-ops, this is very, very crucial. The delirium and cognitive impairment prevention by giving adequate pain control, preferably avoiding opioids, yearly mobilization, optimize the physical environment, to have a good sleep hygiene, like broader rooms, good day sunlight, good airflow, all these things are required. Vision and hearing aids should be given to them as quickly as possible. Remove the catheters like Foley's, IV lines as early as possible. Avoiding psychoactive medications are very, very important. Acute pain management is very, very crucial. It should be multimodal, multidisciplinary. Ongoing education for safe and adequate institution pain management protocol. We do have a pain team in our hospital associated with anesthesiologist, intensivist, and a pain nursing team. Multimodal pain therapy is very, very important. Vigilant dose titration. There is no single dose for a patient at a single point of time. It should be thoroughly assessed every day, every single day. We do have minimum 2 post-op and pre-op pain rounds for all patients in our hospital by our team. Minimum 2 rounds. Pulmonary complication, avoid by doing early mobilization, good physiotherapy, and aspiration prevention protocols like antacids. Most important thing to prevent aspiration is always feed the patient at 45 degrees position, not below that, and keep them at that position for at least an hour or two after feeding. Fall risk. Dr. Bhavaneshvari has given a very good talk regarding this fall risk. Give them the vision and hearing aids as quickly as possible. Scheduled toileting, early mobilization, physio and occupational therapy, assist walking devices. She has given a lot of pictures regarding this assist walking devices. Nutrition, yearly feeding, give them the dentures back. Consider supplementation like vitamins and minerals. Prevention of urinary tract, remove the catheter as early as possible. Yearly mobilization, have a care bundle. Functional decline. How to prevent the functional decline post-op, like care models and pathways. Have a large hall with uncluttered pathways so that they can walk easily. Bigger clocks and calendars so that their time and place orientation will never get disturbed. Sunlight, which is very, very important. Multidisciplinary rounds, which we do. We have a multiple rounds from the anesthesiologist, orthopedic surgeons, occupational therapists, physiotherapists. Family participation in the care plan is very, very important. Yearly mobilization and feeding. Ulcer prevention by yearly mobilization, nutrition, and reduce the friction. So it's a very good weekend with a Saturday night. All we want is a pint of beer, but our beer tells us avoid benzodiazepines and barbiturates, non-benzodiazepines, hypnotics like zolpidem, avoid it. Fortrin, pentazocine, piperine, avoid them as much as possible, and avoid non-COX NSAIDs like Bruf and diclofenac, as much as possible. Recently, the COX NSAIDs like etoricoxib has been used much in this population as possible. Thank you. Thanks, everyone. Thank you. Thanks, Kirti.
Thank you, sir. That's quite explanatory about the pre-op as well as post-operative management of geriatric patients in the anesthesia aspect. So we have some questions for you, sir. So we'll have the question session after Dr. Balamurali's presentation.
Surely, Kirti. Yes, sure.
So I invite Dr. Balamurali now to present about advances in adult deformity management. Welcome, sir. Good evening. Excuse me, sir. Can you please unmute your audio, sir? Sir, you are not audible, sir. Yes. No, sir.
Sir, if sir can rejoin.
Hello, can you hear me?
Yeah, sir, I can hear you, but I request sir to rejoin probably.
Sir? Hello, so Dr. Balamurali has some technical glitches. So we'll go ahead with the question answer session. So,
yes, Kirti.
Yes,
I'm able to hear you, sir.
Can you hear me?
Yes, audible. Yes.
Yes, sir.
Yes, Kirti, you're audible.
Yes, sir. So I have a question. Yeah, sir. So I have a question to you, sir.
Yes, sir. Yes, Kirti.
So you mentioned in your last slide to avoid opioid analgesics and also COX NSAIDs. So what other options do we have, sir?
Yes, Kirti, we do have for the last 10 years, we've been using intravenous paracetamol infusion that gives a very good post-operative analgesia. Apart from paracetamol, we can use selective COX-2 inhibitors like etoricoxib can be used. But in the present era, for orthopedic procedures involving the upper limb, lower limb, or even clavicle, most of the 90% of the procedures which we do here, we either do with a nerve block or we supplement nerve block along with a general anesthesia. We use some additives along with the nerve blocks like dexamethasone, dexmedetomidine, magnesium. All these things will increase the duration of the nerve block up to 36 hours after the surgery. That's the most intense pain period. So that takes most of the pain, 80 to 90% of the pain goes away with that. So we can manage these patients with IV paracetamol and if necessary, COX-2 inhibitors like etoricoxib. That removes most of the pain. By doing this, we can avoid opiate as much as possible. Almost we stopped using opiates like pethidine, all those stuffs in the elderly people. Very rarely we give tramadol only. Even sometimes, even with the tramadol, we used to have cognitive disturbances the next day. So paracetamol, COX-2 inhibitors along with a nerve block. Okay. Nerve block, you have to give additives along with a local anesthetic. That will prolong the block.
Can you hear me?
Yeah, sir. We can hear you now, sir.
Yeah, now good, sir.
So we'll move on to Dr. Balamurali's presentation. Then we'll have the question and answer session.
Hi, I'm really sorry about those glitches. I'm Dr. Balamurali, spine and neurosurgeon from Kaveri Hospital, Chennai. And I'm very pleased to be in this session, which is dealing with some really complex problems that we are going to face more and more in the future in terms of geriatric, orthopedic, spine-related problems. So my topic is going to be about adult spine deformity. So the first thing that I wanted to mention here is that everybody's spine, we have a dynamic and a static component. And as we grow older, there are several changes that happen in your spine in terms of degeneration. You first have a disc degeneration. The degeneration becomes then secondary, involves the facet joints. And this complex of a static and dynamic movement is lost. And gradually, the ligaments become lax. There's collagenous problems, there's ligamentous problem, the tensile strength of the muscles and the tendency decreases. And there's scaptocormia, which is basically trunk and muscle atrophy. And with the aging bone, osteoporosis, sclerosis, osteophyte formation, from a deformity, you start getting an imbalance. So the imbalance is either in the sagittal plane, the coronal plane, or the axial plane. And as you can see, all those air pockets at every level shows a significant amount of instability. And you can already see there is a lot of osteophytes formation and bridging bone, which has all been going on for a very long time. The causes of usually in general degenerative scoliosis or deformity is the degenerative process itself associated with osteoporosis, iatrogenic injury like previous surgery, laminectomy, and kyphosis. So there are two mechanisms, the primary and a secondary. The primary mechanism is when an adult degenerative spine disease progressively becomes a degenerative scoliosis, or you have an adolescent scoliosis at a young age, which is not treated, not recognized, and that gradually then becomes into an adult scoliosis. So both these mechanisms are very important to understand because the secondary mechanisms occur much earlier than the degenerative process. Now, if you look at this, is a very, very interesting slide, which I think everybody should focus and concentrate a lot on, is the instability is interrelated to all of these problems. So instability in the sagittal plane becomes a deformity and causes deformity in both the coronal plane and sagittal plane. And this progresses along with bony changes, fractures, osteophyte formation, causes stenosis. They're all interlinked together. And these things cause symptoms at various levels. So it's very important to identify what causes the symptom, whether the symptom is due to a stenosis, whether the symptom is due to instability pain, whether it is due to nerve root pain. So each of those can have to be addressed separately. And your surgical technique, your approach, whether you do conservative management, how long you will do, all this really depends on this. Presentation usually is back pain. With later on they develop claudication pain, there's radicular pain, disability, kyphosis, Patients are getting very tired because the muscles are really tired. The pain is usually either due to the degeneration itself, the facet arthrosis, stenosis, and also the alignment. So investigations are very important. All these patients, especially if you are planning for a surgery, would definitely need a thorough MRI, a CT. 3D CT really helps you in planning surgery. A full standing X-ray from your C1 all the way up to, sometimes if necessary, up below your knees, because you want to see the problems in the hip joint and in the knee joint if they have severe degenerative changes there. You may sometimes require to deal with the hip and knee before you actually are able to deal with the spine. So a full standing X-ray is required. General health checkup, DEXA scan, I do it compulsorily in our team, and that's because if you are doing an intervention, whether this bone is osteoporotic or not, and if it is osteoporotic, they probably will require parathormone and various other medication to bring their levels better. Pulmonary function test, DVT prophylaxis assessment important. So the decision making is about a long-term discussion with the patient, the family, explaining about what we are going to do, the comorbidities of the patient, the quality of the bone, the amount of kyphosis and the scoliosis, and you have to combine that with your knowledge. It's either a conservative treatment or a surgical treatment. Usually conservative treatment in advanced stages does not work. The patients are afraid for surgery, or you are afraid to do the surgery, and you keep postponing and finding reasons to postpone this. So you either end up doing epidurals, facet injections, treating the osteoporosis, nerve root blocks, and trying all kinds of things, but mostly does not work. So you need to keep in mind constantly about the global alignment. The poor alignment leads to poor disability, and this progressively worsens because this progresses and gradually becomes more difficult. Because your more and more of the spinal cord, the spine is going to shift anterior. So the plumb line keeps shifting anterior. Patients are finding it difficult even to stand for a few minutes. Making a cup of tea is a nightmare. And so there's various studies being looked at into what are the important aspects that you look at, the pelvimetry, the anterior plumb line, and the various angles that you need to measure. And there are lots of classifications, the swab classification, which helps you what type of a curve it is. So where is the apex of the curve? How long do you go with your instrumentation? And the SRS also has for adult deformity. So you need to look into all these when you're planning. This is not a simple surgery. So this is not a surgery which when you're very junior without much experience for you to venture into. This is a surgery where you really have to take into account various things, your hospital setup, and so many other problems. The indication for surgery is usually pain-related deformity, if the pain is persistent, and sometimes the patients finally come to you and say, okay, I've had enough, I want surgery. Curves, the curves that are at risk of progression, thoracic curves, the lumbar curves, they are more at, thoracic curves are more at risk. Kyphosis, what's the degree of kyphosis? What is the sagittal balance looks like? What's the neurological deficit? The patient was severe pain. So preoperative assessment involves all looking at the comorbidities and the spine. And you have to look at the various angles, the sagittal balance. So the adult deformity, basically you're going to summarize it into the pathoanatomy. What is the symptom? What is your diagnosis? What is your decision making? How you're going to, what equipments and facilities you have for your surgery? What is your post-operative, your perioperative, intraoperative anesthesia? Surgical strategies are based on all of these things, and also taking into consideration, are you going to do a decompression only, decompression for fusion, fusion for its deformity correction? If you're doing a deformity correction, what are the levels? How do you end the proximal end? How do you end the distal end? Whether you are going to do a soft landing in the upper part of the curve, whether you are going to go into the pelvis or stop at the sacrum. So all these decisions has to be thoroughly planned before you think about doing this. And the indication as well for surgery, whether which nerve root is involved. You need to do neuroelectrophysiology studies to see whether the nerve roots are compressed, which nerve root is compressed, and how do you decompress the nerve. Because if you just correct the deformity and if you don't do your decompression, and if you don't release the pressure, you may have an excellent looking X-ray, but the patient will still be symptomatic. So understanding the patient's symptoms, and based on that, if it is a stenosis, central decompression, lateral recess stenosis, either a direct or an indirect decompression, whether you want to go anteriorly, with an O-lift or a D-lift from laterally, or you do all posterior, whether you do any osteotomies, whether you do any facet resections. So all of these things need to be planned. And the options, as I said, are plenty. And if you look at the various options chosen based on the various fields, so Bridgewell actually came up with a very popular algorithm where you can decide based on your approach, the degree of your coronal and sagittal balance, and whether the stenosis and subluxation, whether you go down a conservative route or a decompression alone, or what kind of route you take this. And the surgical options are either open or MIS, but the goal is a good fusion, whether it's posterior or anterior, osteotomy and vertebral body resections, good pedicle screw fixations where you have a good purchase, whether you want to do fenestrated screws with cement, you want to use hooks, or whether you want to use whatever you want to use, you need to make sure that you're confident, and how early you mobilize and what rehabilitation you choose. Well, let's talk a little bit about the complications. So the complications are significantly high in these patient groups. As you see that the list is endless. There are minor and major complications. There are patients who are elderly. They have general complications, anesthetic complications, post-operative complications, failure of implantation in the short term, long-term complications, DVTs, MI, chest infections, and bed sores and various problems. So we'll just talk a little bit about complications that can happen. So the perioperative complications are very high in these patients group, and major complications about 11% and minor about 15%. And the major complications are usually permanent neurological deficit, wound infection, pulmonary embolism, bleeding, graft failure, pulmonary complications, DVTs, hematoma. So these are some of the major complications you really need to be worried about in our patient groups. And the minor complications are dural tears, transient deficits, pain, post-operative infection, and wound infections. Late complications are also very important, especially pseudoarthrosis and implant failure can be a nightmare to deal with, because patients are old, they have to have a revision surgery, and implants are broken, rods are broken, you have to re-extend, you have to go higher up or go lower down, you have adjacent segment disease, proximal junctional kyphosis, and various other problems. So the reasons for failure are three. I would classify into patient problems, surgeon problems, and technique related. So patient, yes, if you select the wrong patient, you select an very elderly patient who's got significant comorbidity, smoker, high ASA grade, and a high body mass index. So we do have to operate sometimes these patients. For example, this is a patient that we operated with a significant morbidity, but still the patient required surgery because she was in so much pain with neurological deficits. But yes, so this can fail. This is another patient with the neurofibromatosis, where the patient selection was not ideal, severely osteoporotic bone. So patient selection is the key. And infections are very high after a spinal fixation in these patient groups. Surgeon factors. So again, it comes down to experience and your decision making. What is the approach? How many levels do you go? What is the method of fusion? What are your fallbacks? If you're doing a revision surgery, you're doing second surgery, already somebody's got implants. What do you do? Already somebody's had a decompression in the past, and now you have to go and do an fusion. How do you do? So multiple patient factors. Whether you want to do in a single stage, you want to do in a multiple stage. So this is a young child who had the surgery and progressively things got worse, rod breakage, and as the child grow older, had multiple problems. So how you an adult deformity as you grow older also you need to deal with. Perioperative factors, again, to consider what implants you need. If you need to remove implants, what is the implants? On the day of surgery, the team has to sit and discuss. You may need neuromonitoring. It has to be very, very well planned and thought out. Especially when you're doing revision, do you have the right tools? You have the power tools to cut rods, antibiotic use during the procedure. We do a preoperative DVT screening, and then we make sure that post-operatively repeat one, because these patients are already bedbound, already less mobile, so you can develop problems. So in terms of technique, as I said, if you are not confident about the technique, then you end up with failures. So again, looking at the AO principles of stability, alignment, biology, and function. So function, how many levels are we saving? You use neuromonitoring to do that. Biology, we are doing an anterior, posterior, MIS, what type of graft you are going to use. So for example, this 55-year-old lady with an anterior scoliosis corrected a long time back had a failure. So then we had to extend the entire incision and what type of incision you take. So we went all posteriorly with an Mercedes-Benz incision, and then we go down into the pelvis. So this is how it looks preoperatively and postoperatively. You need to understand the load bearing and load sharing. What is the anterior column defect that you have? And what is the anterior column, what do you support in the anterior column? Because if you have somebody with a TB spine from the past or an osteoporotic fracture, if you don't address the anterior problem, you're going to end up with significant kyphosis and failure. For example, this is a patient who came in with a severe pulmonary compromise, severely osteoporotic. We did take care of the anterior, but look what happens. Even though you take care of anterior, biology is not good, and the patient developed a kyphosis, and we had to go back. Again, open versus MIS, you can use hybrid techniques where you can do a combination of the upper end, we do a hybrid of a minimally invasive, and the lower end, you do an open surgery. So here are some of those procedures which we have done, where I showed you these scans before. They were done earlier, failure of this, and then you have to correct them. So looking at the sagittal and coronal balance, whether you use hooks at the top end for the stability, and laminar hooks, wires, you have a soft landing, you have a double rods. So overall, you need to look at patient problems, surgeon problems, and the technique. So if all three of them match, the success is good. If they don't match, then there is a failure. So I'm just going to conclude by showing you two cases, which we very recently have done. Here is a 68-year-old lady with significant comorbidities, diabetes, hypertension, on anticoagulants, severe osteoporosis, T-scores were minus 2.5 and above, coronal and sagittal imbalance. And I tried to discourage her for several years, but she insisted that she would like to have a surgery because she was suffering. And this is what we did. And she had undergone rehabilitation in our rehab center. And she's been 2 months in the rehab, and now she's doing extremely well. The family are extremely happy. But these are some of the happy stories. You also have failure rates. But if you select the right patient, and this is a very cooperative patient, with 6 months the patient was on Terifrac injections, and the patient's scores were increased, osteoporosis was dealt with, and we did a very good surgery. And the second procedure, again, a similar 72-year-old patient with severe low back pain, restricted activity, and this wasn't completely MIS. And this patient also did extremely well, though the degeneration and the scoliosis were not significant. She was very symptomatic. So we did multiple level decompressions. So in conclusion, degenerative lumbar scoliosis will likely become an increasingly recognized problem as we live longer, as we have prolonged life. We want better quality of life. We are going to be treating more and more, and we cannot refuse, because if you refuse, your colleague next door is going to operate. So you might as well learn to do these techniques and be competent and understand the biomechanics. So conventional surgery can be effective. Open surgery is best for majority of these patients, but a lot of MIS techniques are coming up, and if you're confident, you can get excellent results. But always remember, your first operation is the most critical. And if you do a wrong operation for the first time, you could end up with various complications, and revision surgery is a nightmare. So I wish you all well, and I hope that you are able to do more of these for those who do spine surgeries. So you can give a good result, you can give good outcomes for these patients. Thank you very much for the opportunity. Off to you, Dr. Kirti.
Thank you, sir. That's an excellent presentation about adult degenerative scoliosis, covering almost all aspects of degenerative scoliosis. So now we have some questions from the audience. Ma'am, Dr. Bhavaneshvari, we have a question for you, ma'am. So is there any option to avoid falls in elderly totally, to make them totally resistant to fall?
That would be a utopian world that we live in. We all wish that could happen. But unfortunately, we must understand that aging is a kind of degenerative process. And as I was mentioning earlier, it's part of the intrinsic factors that makes somebody a little bit shaky and more prone to fall, we can't change many things. But what we need to understand is high awareness about the risk of falls. Not just the doctors, not just the patients, the families, the caretakers, everybody should be educated. It's important that the risk of fall in that particular patient is assessed just for that patient. And then we address the problems one by one, making sure that we minimize the risk of falls to a maximum. Yes, we all want a world without people falling and breaking bones, but it is not possible. And I'm sure our orthopedic colleagues who have been talking so much, they would also want to intervene correctly for these patients. And the right approach, prompt treatment makes a huge difference to the quality of life. Thank you.
Yes, ma'am. Yes, it's quite understandable, ma'am. And we have another question to Dr. Velmuragan. Sir, you have mentioned about regional blocks along with painkillers.
Yes, Kirti.
Yes, sir. So do you prefer regional blocks or a general anesthesia for elderly patients, sir? Especially in upper limb injuries, where the patients are mostly delirious and uncooperative. Do you prefer a general anesthesia or regional blocks?
No, I would personally prefer a regional anesthesia, regional blocks, because for two reasons. One thing is there is no hemodynamic compromise with the regional blocks, whereas neuroaxial as well as the general anesthesia has some sort of hemodynamic compromise. Second thing, we are not at all involving the pulmonary component by giving a regional block. So I always prefer a regional block better than the general anesthesia. But a lot of studies has proven that there is no big difference between a general anesthesia and regional and nerve blocks as taken as alone. But I would prefer nerve blocks.
Okay, sir. So another question to you, sir. So if a patient presents with a severe compromised cardiac function with a poor left ventricle function and pulmonary reserve, how safe is the perioperative journey of the patient in the post-operative, especially in the post-operative period?
Okay, that's very, very important question, Kitty, because 50 to 60% of the patients coming to us for surgery, that is a geriatric population, have some sort of either lung or heart compromise. They have a poor LV function, poor RV function, or a COPD. For them, first the pre-op optimization is.
Sir, you're not audible. Sir, you're not audible.
1 minute.
It is okay. It is okay.
Yeah, we can hear you, sir. Please continue, sir. We can hear you.
Okay.
Yes.
So the pre-op optimization
We're not
able to hear now.
Able to hear you. Any one of you.
Yeah, we can hear you, sir.
Am I audible?
Yeah, it is okay, sir.
Yeah.
Okay. So the for hemodynamically poor reserves patient, like for an example, a person with the LV dysfunction of 20 to 25% coming for a hip surgery or a upper limb surgery, there are three ways we can anesthetize the patient. One is the neuroaxial anesthesia. Neuroaxial anesthesia is contraindicated with poor LV dysfunction, for an example. You cannot give a regional anesthesia. That is neuroaxial anesthesia. So we have left with only two options. One is a general anesthesia or a nerve block. As I said earlier, general anesthesia has some sort of hemodynamic compromise. We have to start them on inotropes, vasopressors like noradrenaline. We have to put an intra-arterial line, invasive lines, and post-op we have to closely monitor them. May require to ventilate them a couple of hours in the ICU if we give a general anesthesia. For an example, but if we're going to give a nerve blocks, for an example, coming with upper limb fracture, or those who are coming with, for an example, coming with a fractured tibia, we can operate them with a nerve block like femoral and sciatic nerve block or lumbar sympathetic plexus block. That will never compromise the hemodynamic. There won't be any drop in blood pressure. Not even 10 mm mercury of drop in blood pressure will be there with a nerve block. What else we want? So very, very rarely we place invasive lines if we are going to do a nerve block. And there is no post-op ventilation. So definitely with hemodynamic compromise, nerve blocks are preferred over GA or a neuroaxial block.
Okay. So we have another question to Dr. Bhavaneshvari. So is there any need for gait assessment in clinics on a regular basis, ma'am, especially for the elderly patients? And which patients need those kind of gait analysis and further follow-ups?
I think all elderly patients in a geriatric clinic have to be assessed in terms of their ability to walk, turning, how fast they're walking, the walking time, 10-meter walking time. All these things have to be part of the assessment. In neurology clinic, this we do regularly. Many of my patients, I even make them walk up and down in the corridor because I want them to walk longer distance, not just the short distance within my clinic, because I want to assess their gait better. And certain patients, I even ask them to climb stairs and assess their ability to climb stairs, proximal muscle power assessment. All this have to be done as part of your consultation for patients who are over 60, whether or not they have medical problems. Of course, if they have medical problems like previous stroke with mild disability or Parkinson's disease or neuropathy, then as gait assessment is mandatory.
Sir, Dr. Balamurali, sir.
Yes.
Yes, sir.
Yes.
So we have a question to you, sir. So how long do you give injection teriparatide before venturing into surgery?
Yeah. So depending on their DEXA scans, T-scores, normally, ideally, you need to give them from anything from 6 months to 1 year, especially if their T-scores are osteoporotic, more than minus 2.5. So ideally 1 year, but a minimum of 6 months, along with supplemental calcium and vitamin D. And I would repeat it before you do the surgery as well. So longer the term, 12 months, 18 months as well is suggested if the patient can wait. But majority of times, your patient is not going to wait for that long. They either just go down the conservative route and they don't come back to you. But planning at least for 6 months to 1 year, like the patient which I showed you, we treated her for almost 8 months. And the 9th month is when we operate.
Yes, sir. So we have the next question to Dr. Bhavaneshvari. Regarding falls, is it always a neurological cause, ma'am, or it can be syncope or cardiac issue or anything else?
Yes, you're absolutely right, Dr. Geeti. It doesn't have to be neurological all the time. A simple aging can also increase the risk of falls. As they get older and older, there is intrinsic factors like, when patients are walking, even their perception of depth can be a little bit lower. Light and dark adaptation of vision, that is compromised a little bit. Many a times you will note when you talk to them, the history is fall when they're trying to go to the toilet. Just in the nights, they've just got up, they've not switched on the light. So teach them simple things like, when you get up from bed, take a few seconds, just sit on the edge of the bed, stand at the edge of the bed, holding on to the rail, stand for a few seconds, stabilize yourself, then start walking. Switch on the lights, make sure the room is well lit. If you are a little bit frail, then wake up your partner. It's okay. Just make sure that there's somebody who knows you've gone to the toilet. So simple things like this are important. And we need to keep on telling the patient, reiterating to the patients about these risks. Tell them, as I said, the very important maneuver is when they get up from bed in the mornings or in the nights, it's important that they don't just jump out of the bed and start walking. Take a few seconds, stabilize yourself and go. Syncopal episodes, yes, they are dramatic. Patients come to you with history of loss of consciousness. Most of the time, patients think they've had a seizure, but it need not be a seizure all the time. It could be simple blood pressure falling. It could be hypoglycemia. It could be cardiac, especially patients who say history of I fall, I lose consciousness, I get up immediately and start walking. Then you have to think cardiac. This brief episode of loss of consciousness and very quick recovery never happens in neurological problems, especially seizures. Most of the time, there is even some minor confusion or disorientation that is there. If the patient recovers very quickly, definitely you need to think cardiac and that needs to be evaluated. So syncope, yes, it's dramatic, but simple tripping and falling, let's also not neglect that.
Thank you, ma'am. So another question about adult scoliosis, sir.
Yeah.
So what is your patient selection criteria?
So, I mean, as I was discussing in the presentation, the selection criteria cannot be just given in a simple 4 or 5 points. So, as I said, we have to look into patient factor as to what is the symptom. What have you tried in terms of conservative management? Have they failed a period of good conservative management? You've tried facet joint, epidurals, and how long have you waited? I would never ever suggest an elderly person who comes in, even with a severe worse deformity, in your first consultation to say, let's do surgery. I would meet them at least 3 times to 4 times, talk to them again and again and again about the risks, the benefits, the risks, the benefits. And even it gives you time to prepare yourself as to what you're going to do. Because it's not like straightforward, okay, let's fix from there to there. It does not work like that. So you need to look at their biology, their bone. Your first consultation, you investigate them, do a DEXA scan, put them on teriparatide, calcium, explain to them. Most patients, by the second conversation, they disappear because they listen about all these complications and they don't want to take a chance. Or somebody in the family or another doctor will take them away. They say, don't go for this. That is what happens in most of the times. Because patients are not ready to accept the complications, and it is not like a straightforward surgery. And then if patients come to you by a 3rd consultation or 4th consultation, then you know that the patient is motivated, the family is motivated, and you're all talking about the same thing. So they all need to understand the worst case possible. So that's in terms of patient. In terms of the procedure, as I said, we have to plan with everything, X-ray, MRI, alignments, hips, knees, everything. And then the technique as such, depending on your curve, you see what you're comfortable with. It does not mean that you always have to go anterior, you always have to do O-lift or D-lift. You do what best works in your hands. Whether it's a combination of open or MIS, you can go all posterior. The cases that we showed you, they're all in their 70s. We're all posterior. And we had excellent correction and excellent clinical outcomes. So I think these are all the things. It's complex decision, but the key is that you and the patient and the family understand the worst case possible. Because you may do a fantastic surgery, but the patient's body condition may not be good. They may not be able to withstand. The patient that I showed you where we did from a T4 to pelvis, she had 14 units of blood transfused. 7 to 8 units was transfused on table. And another 6 units in ICU. 2 months down the line, she's very happily walking. But it was not an easy journey for the family and for us. So I think, these are things that are important in selecting patients.
Thank you, sir. So coming to the last question. So this is to Dr. Velmuragan. So as Dr. Aravindan Selvaraj has mentioned, it's still controversial whether to take up a patient who was on clopidogrel or an ecosprin or combined medications for a long duration. So what is your protocol, sir? Do you take them immediately for surgery, or do you prefer a regional anesthesia or general anesthesia of the patient? What's your protocol?
Yeah, those patients, as Dr. Aravindan has told, those patients can be taken up for surgery. Okay, only thing we won't be able to give neuroaxial blockade to them because that will increase the chance of spinal or epidural hematoma, which is disaster. So it's absolutely contraindicated. So those kind of patients, what we can do is we can do it under general anesthesia with a nerve block. The only thing is the surface might be a bit oozier. So the risk, which we are going to take, it's our call. Okay, as Sarah was told, that's true. Suppose a patient is going to lie down for 5 to 7 days in the hospital, the chance of getting a pressure sore, urinary tract infection, pneumonia, getting depressed, disoriented are very, very high. So by considering that, we can take up a chance, maybe in a day or two, couple of days, we can take them up for surgery with general anesthesia with a nerve block. That can be done. Yes.
Okay, sir. So I hope this is a very informative evening. So we are almost discussed every aspects of geriatric medicine in the surgical aspects actually. Thank you all speakers.
Thank you. Thank you. Thank you everyone. Thank you.
Good evening, doctors. Yeah, I am Durai.
I want you to give your vote of thanks, please. Yeah.
Yes, sir.
Yeah.
Good evening, doctors. Myself, Durai. I am behalf of Intas Biopharmaceuticals from the makers of Terifrac and Olimab. I sincerely thanks to all viewers to spend your valuable time for the wonderful program. And my special thanks to Aravindan sir and Dr. Balamurali sir to given the valuable opportunity to collaboration with the Kaveri Hospital and conduct a wonderful program about geriatric issues and the treatment option. And most of the issues carried about osteoporosis and osteoporotic fracture, we have the better service to our patients through Terifrac and Olimab. So whenever and wherever your patients, we are ready to support them. And I sincerely thanks to today moderator Dr. Kirtivasan sir and speaker Bhavaneshvari madam and speaker Velmuragan sir to given your valuable time for the program. And thanks to Dr. Neeraj from OrthoTV and thanks to Kaveri Hospital IT department to arrange all the program in a wonderful way. So once again, I thanks to all the viewers and speakers to spend your valuable time for the program, sir. Thank you, sir.
Thank you.
Thank you all very much.
Thank you all. Thank you.
Thank you.
Thank you, sir. Thank you so much.
Thank you.
Thank you.